We were interested in the possibility of a prodrome in NMOSD and MOGAD because of all of the evidence that has been accumulating over the last few years, suggesting a prodromal phase in multiple sclerosis. And we also know that there are prodromes in many other inflammatory and neurodegenerative diseases, but it hadn't been investigated so far in NMOSD and MOGAD. And for NMOSD, anecdotally, talking to patients in our clinic, we found that some patients did report nonspecific neurologic symptoms in the years leading up to their NMOSD diagnosis. So, for example, we had patients who reported sensory symptoms like numbness and tingling that would come and go, or some episodes of severe neuropathic pain before their first classic NMOSD attack. So that got us thinking whether there could be a prodromal phase to NMOSD, and we were interested in this in MOGAD as well because there have been some reports of patients having severe headaches or incidental finding of optic disc pallor or atrophy on investigations before onset of their disease. So we decided to investigate this systematically using health claims data. We took a similar approach to what had been done with the multiple sclerosis prodrome in investigations led by Helen Tremlett's group. So we looked at utilization of healthcare in terms of hospitalizations and also outpatient visits in the 5 years leading up to each of NMOSD and MOGAD. But for each of the NMOSD and MOGAD cohorts, they had their own set of matched controls. So we matched controls on the basis of sex, birth year, and also geographic region. And then we compared health service use in the cases to controls over the 5-year period before clinical onset and also in each year before clinical onset. For the NMOSD cases, we did find evidence of significantly increased health service use in the cases compared to controls, and that was for both hospitalizations and also outpatient visits. But that wasn't the case for MOGAD. And then when we looked at health service use annually, we found that health service use steadily increased in NMOSD cases in the 2 years leading up to clinical onset, which is actually a pattern very similar to what is observed with multiple sclerosis. For MOGAD, the rate ratios were actually completely flat at 1, indicating equivalence between cases and controls for all of the years except for the year immediately before clinical onset. We don't know exactly why we saw increased rates just in the year before, but it could be related to direct triggers of disease pathogenesis. So, for example, we know there's a high prevalence of infections just in the month or two before MOGAD onset, which might be a triggering factor. So we're hoping to investigate that some more in further research. It could be, when we see there's a prodromal phase to a disease, it suggests that the underlying pathogenesis is actually starting sometime before clinical onset. We know that's the case with multiple sclerosis, and that's been shown, through other studies that have looked at blood samples that were available from individuals before clinical onset, and we saw that levels of neurofilament light chain were elevated going out, some years before MS onset. So it suggests that there's underlying biologic pathology. So I think the same studies need to be done for NMOSD. We need to find blood samples from people who later develop NMOSD, in the years before clinical onset. And we need to look at biomarkers that have been found to be quite specific for NMOSD, such as GFAP. NFL might also be interesting to explore, but I think, looking at the GFAP levels might really be key. There have actually also been some studies investigating the aquaporin 4 antibody. There have been case reports that showed that there have been cases where people had positive aquaporin 4 antibody in blood samples collected years before clinical onset. There was recently a more systematic investigation using the U.S. Department of Defense Serum Repository, and they found that more than 50% of people who developed NMOSD actually had evidence of the aquaporin 4 antibody in their blood, going out 2.5 years before clinical onset. So that suggests that pathogenesis probably does start, at least in some individuals, quite a few years before clinical onset. And that might be a missed opportunity for recognition of cases and possibly prevention in the future.